of Women in Endoscopy endoscopic feature on peroral endoscopic myotomy. We have here Mohammed Hassan from the Center of Interventional Endoscopy at Advent Health in Orlando, Florida. Thank you so much for being here. And please share with us about your equipment and the techniques that you use. We also have Dr. Ara Sahakian, who will be moderating as well from USC. Thank you.
Thank you. Thanks for having us today.
Yeah, thank you for having us. So this is a first. It's an explant tissue. It's not a pig model or not a live live blood flow in there. With regard to scopes, obviously you can use different scopes, whatever you are really comfortable or what you are used to. You can use Olympus, Fuji, whatever you want to. Scopes also have different working channels, diameters. Olympus one has 2.8. There's a Fuji available, which is a 3.2. You can use different caps as well. My go-to cap is usually it's a beveled cap. It's a RFA cap. And the end of it helps you get into the tunnel. But you can use a Fuji cap, whatever you are comfortable with. So you're using a Fuji scope, Fuji cap, or using a RB system, and this is a different generator. If you have a other generator, you should be familiar with the settings which are going to work for home, and you can adjust settings based on your generators. Different knives as well. Here we're using a RB knife. There are different type of RB knives: I knife, T-type, I-type. So I is like really straight, and like a knife coming out, like a needle injection comes through that. And whatever your preference is, both would work. And I don't know what your preference is, Annie, on that.
So I prefer the iKnife. I think I find a lot of people starting out like the T-knife because it has the little plate to help you do the myotomy. But when people gain experience, I think a lot of people seem to switch to the iKnife. Okay. I don't know what your preference is.
Mine is I. I usually start with the I. I do a myotomy with the I too. So I hardly use a T-type.
Maybe cuts a little bit easier with the iKnife than the T-knife.
And also, like when you have to use a different type of cautery, like a spray, it works really well for you. Better with the spray. Yes. Other thing which I really want to stress on is where your injection foot pedal is and where your cautery is. Try not to put those together beside each other, because sometimes if you are not looking at it and you are thinking you're using an injection, but you may misstep on a cautery, and that's not what you want. So what I do is my injection paddle is on my right foot always, and then my cautery paddle is always on the left. And there's obviously blue paddle, yellow paddle. I put my foot right in the center. You can really rest on there. So you don't have to keep looking back and forth. And I can move foot to the right, foot to the left. So based on that, what type of cautery I really need. So coming back to now your scope, other important thing, the cap, we mentioned about that. And in this Fuji cap, if you use the Olympus cap, it has a hole on one side. The Fuji cap has two holes, if you look at that. So if we were talking about earlier as well, if your hole comes straight where your working channel is, which is at 7 o'clock position, your knife is going to get stuck when you're trying to push that out. So keep that in a way position that you're really, those holes are on the side. But if it's one hole, you always want to be on the opposite side of a working channel because you don't want the tissue get stuck there between the channel and that hole, and also it's going to be problematic pushing the accessories out. We're just going to demonstrate the technique of foam, like type 1, 2, 3. We won't go into those details. Bottom line is, let's suppose it's type 1 or 2. You don't need to do like a 10 centimeter long tunnel. You can use a shorter tunnel, like 7 centimeter. That's what I end up doing mostly now. And then just have your myotomy maybe 4 to 5 centimeter above the GE junction and 1 to 2 centimeter beyond. That would take care of that, your achalasia.
That's about what I do as well. We talked a little bit about how you like to use the RFA cap. I use the Fuji taper cap. Can you talk a little bit about how these caps that are a little bit more tapered, or in your case a softer cap, how does that benefit you?
So that's a good question actually, because the distal diameter really matters. That is going to matter in a way like how much of a incision you are going to make, how that's going to help you get into the tunnel. And especially if a tighter space, you need a smaller distal end cap.
Right.
Fuji would work really well. If it's in the stomach, you're doing a G-pone, it really doesn't matter. You have a lot of space there, so you can work with that. If you're doing a Zenker, you really need a very small distal end cap, and that would be a Fuji cap, and that would work really well.
You can make a much smaller incision when you do a Zenker when you're using that.
Absolutely.
Nice.
And Zenkers, if you have a longer Zenker, it's much easier to deal with that. It's the shorter one which really gives you a smaller ones, which give you a much less space as compared to the bigger one, and that's where this small cap and small incision really helps you. So here back to POEM, and in this one, GE junction is right here. I'll come maybe 4 or 5 centimeters above that. I will ask your preference, but my preference usually is the anterior approach. Everybody has a different anterior, posterior. We have evidence, both work, whatever you are trained in, whatever you are comfortable in. But if somebody already had a hilar myotomy, you gotta go posterior position. If somebody has a sigmoid esophagus, really big diameter of that, you would not be able to enter into the tunnel in anterior position. You gotta choose that posterior position.
We learned that one the hard way.
And the way you do anterior posterior, it's much easy. Patient is laying on their back. That's how I usually put them. And you put a fluid into the esophagus. Wherever it's accumulating, obviously that's a posterior. And then based on that, and sometimes if you feel like your scope is more comfortable, what you really want from scope is to be useful to you. Scope should not be in stress. You should not be in stress. Your left hand should be controlling the scope. The right hand is justly advancing or pulling back using accessories. So scope should be, there should not be loops in the scope. If you are shorter like me, you can step back away from the patient. You want to keep the shaft of the scope really straight. And if you're taller, you can stay closer and keep the scope up. So that way, whatever you're doing, basically it's more important even for the EUS, CRCP scope. Whatever you are doing at your left hand, that needs to be equally transmitted to the distal end of the scope. It would not happen if your scope is not comfortable and if it's not straight. And use your shoulders, use your wrist to rotate the scope or move the scope. Your right hand should be free to use accessories, and again, just to push or pull the scope. So we're going to
talk a little bit about where you make your incision in comparison to the G-junction, because when you do your mucosotomy, it's going to take you down a couple of centimeters, right?
So we talked about like we're going to do 5 centimeters. Let's suppose I want to do a 5 centimeter myotomy above the GE junction, including up to the GE junction. So I need minimum of 2 centimeters really above that, because I don't want to be cutting the muscle right where the incision ends. So 2 centimeters above that area where I started the myotomy. And if I want my incision to end 2 centimeters above, I need to start 1 centimeter to 2 centimeters further above that. So in this case, what I would do is let's suppose I'm 5 centimeters above here. I want my incision to end there. Actually 7 centimeters above. I want my incision to end there. I'll put a couple of centimeters back. And what you can do is, I'll show that how to adjust that in a little bit. Other thing about terminology, I was talking earlier in the lecture as well. Terminology in your unit needs to be same. Needle in, needle out means different to different people. So what I usually say is needle into the patient or out of the patient. So even if it's a new tech, new nurse, they know exactly what I'm asking for. And so here, needle into the patient. So that's what it's like. It's much easier, because if I say needle in or out, it could be in and out different to anybody. Yeah.
And that's a good point, that your tech needs to be, when you're doing these complex procedures, the technician sort of needs to be in sync with you.
Exactly.
Right.
So, and also making it uniform in your unit, because that in our unit, we say it differently.
Yep.
I do what you do.
Yeah, exactly. And it's just like, so everybody's on the same page. when I do the injection, it's like an injection for any, be it a resection, be it a tunneling. As soon as my needle, and actually with this one, I don't know how you do it. What we do is we take a saline first. We make, like I don't want to inject the thick solution first. So what I'll do is have a saline connected. As soon as I touch the mucosa, I'm going to ask her to slowly start injecting. Slowly start. You see the injection? When she did, I'm going to push the needle in. So what needle does is it finds the submucosa, and be careful in this pig itself. Sometimes it's so thin muscle, it's hard to find that. But you saw that. Like injection starts before the needle goes in.
I think what we're often taught in fellowship is to
push it
first,
and pull it back.
And I think the more and more we do,
go ahead and inject a bit more.
Many of us are injecting on the way in to find the layer.
Yeah, exactly.
So we don't go through the muscle.
And so then when it starts making a bleb or it starts going into the submucosa, I ask my nurse or tech to switch it to head-a-starch or whatever thick solution you are going to use, and then go ahead and make that bleb. And in pig and especially explant, there's not fluid in there, so it becomes really, really thin, and it's already thin wall to begin with. So here, go ahead and inject that a little bit more.
That's interesting. You talked about injecting with saline first. That, we use that also for tattoos, so that we don't shoot our tattoo ink.
Needle out of the patient? Okay, let's give me the knife.
Once you get the bleb, you can switch your syringe, and you just leave the needle right in there in the bleb, and you can switch your syringe over to the tattoo, and you get a very nice clean mark.
And same area where you made the initial injection, use that at your really starting point. The way I do is, I'll show that in just a second. Other very important thing, you need to know the length of your knife. There is a 1.5 millimeter knife, there is a 2 millimeter knife, there is a 4 millimeter knife, 5 millimeter knife. Your esophageal wall thickness, or any, for that matter, anywhere in the GI tract, the wall thickness can range from 2 millimeter, and that includes all 4 layers, all the way to the 3.5 millimeter. If you don't know the length of your knife, you may just go straight through the wall, through the muscularis propria. So very important.
And what's your preference for POEM?
For POEM, I use a longer one, a little bit. The reason for that is some of the knives, they are not able to, you cannot connect those with the pump. This one, you can connect. There are some other knives which you can inject through the knife, but still will lack pump. So for POEM, my preference is usually, it's not like it's a RB station, but that's my preference usually to start with.
I think a 4 to 5 millimeter is a nice spot for POEM.
Yeah, go ahead and knife into the patient.
Thick muscle layer when you're dealing with achalasia, and if you use a short knife, you're really stuck just doing a lot of work on the myotomy.
Yeah, so I'm gonna use the same area where I had my needle right now. I will put a little gentle pressure with my knife, and I'm gonna do one thing only right now. Just a little tap, just one tap, that's it. That takes your knife in there. You want to be a little bit more careful when you start the incision, because you don't want to cut the muscle right there, and then you have to find another place. So knife goes in, I do an injection right there, right away. And once that is done, I'll pull the knife back. First, I usually go, incision is, by the way, with the yellow paddle or endocope, and you want that deep. You don't want a superficial incision, because your bleeding happens from muscularis mucosa, and that's a small bleeding, annoying bleeding. But bigger bleeding will happen from submucosa, but the smaller annoying bleeding happens from the muscularis mucosa. So you want to be beyond that. You want to cut the muscularis mucosa and be in submucosa. So I have my needle there. Now I'll keep straight up, inject, and like a little bit wheel towards me, and I'm moving up, pulling the scope back.
Well, that's interesting. So you start by cutting upward.
Upwards, okay. And from there, I will, after I have done that, I'll inject. Now everything is under control. I'll put a tip right on there at my cut and go down.
What do you do?
I cut downwards, so I thought this was really fascinating. I'm curious what the reasoning is for starting by cutting upwards.
Because I have more control of that, and I want to get into the submucosa. When I go down, I want to see I'm not into muscularis propria. When I'm going down, I don't have that visual of that.
Yeah.
So that's what I do. Yep.
Learning something new every day. Yeah.
Oh, we all learn from each other, absolutely.
I actually sometimes will go upward on my myotomy in some situations.
Yeah, so that's exactly what I do. Like I'll do that up, and then once I find the plane, then go down.
Right.
And then from bottom up, sometimes few fibers left. That few fibers which are left, I usually cut those up instead of going down.
I find sometimes that during the myotomy, when you're so close to the mucosa behind you, going downward risks sort of flinging your knife into the mucosa. But when you're in those tight situations, cutting a little bit upwards can be a safe maneuver.
And there is not much submucosa, to be honest with you, here, because it's a very, very dried out, but we still are safe here. What I did is I'm going to inject right here, see if I can find any submucosa. Now, and the other thing is, like, you want to use a little bit of cautery here because your vessels sometimes they bleed, and you are just from the edge of the wall on both sides like that. And sometimes the vessel is right at the lower edge, right here. So just do a little bit trimming, kind of what we call, and with the knife like that. So all that is now nicely set there. Now pull the knife back into the scope and see if you can get into the tunnel right there. Okay. And
very nicely done.
so it's
Clearly, we don't have enough time to do the full
Yeah.
poem, but any last tips that
So-
you want to make a point?
when you get into the tunnel, once you have done that, yeah, this is all like not really much submucosa. So main thing is to keep your orientation. I'm going to come back here. You gotta make sure that you have enough space because it just it can cause a lot of cautery and it goes deep sometimes. So here, actually, this is the point I want to the tip. One of the tips goal is to stay straight into the tunnel. You don't want to be swirling around into the tunnel. And what happens with the esophagus is much easy, and especially in the anterior position, your circular muscle is like that. Just maintain that orientation and keep going that. Anytime it twists to one way or the other way, you are swirling there. So just keep that in that one nice concave position right here. You see that muscle there? There's not much submucosa honestly here. That's why we're seeing that a little bit. I'll just go ahead and do some myotomy right here. So first, myotomy is going to be done with the endocut. Now it's with the cut. So I'll hook a little bit right there. One tap. Big wheel towards me, coming up in straight line, coming up. As long as I have a control, I'll go that. Now, right there, I created a space for myself to put my knife there. So I'll cut a little bit more. Let me just do a little.
You're essentially trying to isolate the longitudinal muscle layer.
You want to go into between the circular and the longitudinal. As much as you can protect the longitudinal, that would be great. Some benefits of that, and usually it's not possible. Sometimes it's not possible, especially when you are close to the GE junction. But if you can protect it, that would be much better. That less risk of infection and also less risk of reflux as well.
It's a nice barrier there between us and the mediastinum. And I see you're nicely demonstrating that. We can already see the
longitudinal. You see that outside?
Beautiful.
Yeah, so that's how, once you have that, you created that plane, then you hook your knife right at that plane, just controlled one, right there, and go down.